Tēnā koutou, tēnā koutou, tēnā koutou katoa, which is Māori for greetings, greetings, greetings to us all. I'm the Executive Director of Planning, Funding and Decision Support in Canterbury, so that's the analytics. And I'm going to take you on a little bit of a tour. It will take a little bit of time because the story is now 12 years long, so it's got quite a bit in it. And then I'll be really, really happy to answer questions. I'll try not to make you seasick as we go, but just to give you a sense, district health boards in New Zealand are what are called Crown-owned entities. So we have our own board. That board is two-thirds elected and one-third appointed. In fact, I'm over here in trepidation wondering who's going to end up on our board because we just had our elections. So I know who the elected people are, but I'm waiting for the government to make the appointments. And then we'll find out who our chair is. So it's always every 3 years we change our board. We are funded by the Ministry of Health on a population basis. So we get a certain amount of money to look after the health and wellbeing needs of our communities. We own the public hospitals and employ the staff that run those public hospitals, but we fund by contract the community-based setting. So we fund primary care, that general practice, broader primary care. We fund community nursing, district nursing, mental health through the non-government organisations. We fund long-term care for the elderly. So a whole range of services that we fund across our health system. So when we started this, because district health boards go back to the early 2000s, the Health and Disability Act that led to district health boards in 2003 was one of those times when people were very forward-thinking. And they imagined a system that was cooperative and collaborative and integrated. That isn't actually what happened. Now, the reason that didn't happen is because district health boards were grown out of what used to be the hospital and health services. So the hospital and health services were then given the funding for the primary and community setting, and nobody trusted them. Because they thought actually all the money was going to go to the hospitals, because isn't that what happens in most places in the world? So what happened was the planning and funding function as it existed then was set up as an arm's length function. So it acted like the old funder-provider splits that you had in, say, the UK. It acted like an arm's length commissioner. So it tried to run the health system by contract. And everyone was competing for the resources, and people were arguing at the boundaries. It was all about contracts. There was no information sharing, there was no connection, there was no working together. So that was what Canterbury was like prior to us starting our new journey. In fact, Canterbury managed to do that on speed. So the planning and funding function of the Canterbury District Health Board functioned behind a locked door. A locked door that nobody else was allowed through either, including the Chief Executive of the District Health Board, because he was seen as he was running the hospital, so therefore he was conflicted. So the planning and funding function wouldn't talk to him either. At that time, our primary health system was good. It was actually a high-functioning health system that had gone through all of the reforms, because like everywhere else in the world, we've reformed the health system a number of times. But the secondary care-based system was not working. So Canterbury cancer patients were more likely to wait for radiotherapy. We had an overcrowded ED, gridlocked hospital. We cancelled surgery every day during winter. We missed our electives targets by 30%. And we really made the front page of the paper all throughout New Zealand. When the government put some pressure on Canterbury to meet the waiting times targets, that's waiting for elective surgery or waiting for access to a specialist, and the waiting times target in those days was 6 months. So to avoid the financial penalty, Canterbury removed everybody who'd been waiting longer than 6 months. So essentially on Tuesday, 5,000 people got a letter that said, I'm sorry, you're not on the waiting list anymore. I was actually the chief executive of the primary health organisation at the time, and I had GPs in my office in tears because they were so frustrated, having spent all this time waiting for patients to get the right answer and then having them thrown off the list. So we got hold of the list and we went through it, and we discovered exactly why the system didn't work. And it was largely because nobody knew what anyone else was going to do. GPs didn't know what the criteria were for selection. They didn't know what the secondary care specialists were going to deliver. They didn't know when they were going to say no and when they were going to say yes. So they were actually sending patients to 3 different departments at once just to make sure they might get through in one of them. So it was actually largely about communication and working together. We made a commitment to ourselves as a system at the time. We're never going to do that again, ever, where we're going to remove patients from the waiting list. So, about us. To give you a sense of size, Canterbury looks after a population of close to 580,000 people. We are the second largest district health board in the country by population and also by geographical size. It's about 3.5 hours on a land basis from the furthest point in Canterbury to the main hospital. But we also look after a little island that's 3.5 hours flying time off the coast that has 600 people in it. So we're used to remote rural as well as large urban. Our population is growing, as is most of New Zealand, largely by immigration. And in our case, it's also ageing. We have a slightly older than national average population. And we also are growing quite quickly in terms of the Māori population, which, like most Indigenous populations in the world, has poorer health outcomes. We employ about 10,000 people in Canterbury running the hospitals, so that's the acute hospital, our rehabilitation hospital, our mental health facilities, our women's and children's hospital, and also some smaller rural hospitals that we still have given the spread out nature of the system. When we started this journey, as part of a health services planning process that I'll talk about shortly, we did some analysis. At this stage, I had changed sides. I'd been conned into taking on this job by the chief executive of the District Health Board, who thought he might have more chance of integrating a health system if he had someone working for him who understood how the primary and community system worked. We did some analysis and we said if we kept on doing what we're currently doing, then by 2020 we're going to need 400 more hospital beds, 2,000 more aged care beds, and another 8,000 people working in the health workforce. That was the analysis that galvanised an entire health system to go and do something completely different. Because we knew we weren't going to get 8,000 more people working in the workforce, so there was no point building the 400 beds because we wouldn't have anyone to staff them. So that's when we started our journey towards an integrated health and social care system and across an entire health system. Before I tell you how we did it, I'll just tell you whether it works. So, excuse me for the cough, too much talking. This is our health system's strategy plan on a page. That's Agnes. That's Agnes in her home. I must admit we don't build really good housing in New Zealand, so that's a classic New Zealand-based bungalow. It probably doesn't have any insulation and it probably has single glazing. But anyway, that's Agnes in her home, and her services supporting around her to keep her well and healthy in her home and out of our institutions. So that picture was borrowed, the original concept of that picture came from the Redbridge Trust in the UK, but we adapted it to make it look like the Canterbury health system, and that acted as the guiding point for the entire Canterbury health system since 2008. Before I tell you our results, I'm just going to walk you through our population. So since 2006-07, our total population's gone from about 470,000 to close to 580,000. So 110,000 more people in Canterbury. It's also, the older population's gone from about 65,000 people over the age of 65 to 94,000 people over the age of 65. Now we all know that older people are the people that drive health service utilisation. Our Māori population's gone from about 30,000 to 54,000. So we've seen significant increases in those populations that make particular use of health services. Keep that one in mind and we'll look at the results. So, a couple of key measures. We have a number of key measures in our system. We have an outcomes framework and we look at particular measures about how a health system, how you can know whether a health system's going in the wrong direction or the right direction. One of our measures is ED attendance rate. So what you can see here is the Canterbury ED attendance rate versus the national ED attendance rate. It's about 25% lower than national, and we've managed to maintain that. Most importantly, the attendance rate for the people over 65, because we did early analysis that showed us that the biggest driver of all of these people ending up in aged residential care was frail elderly people ending up in our emergency department, and then us not responding in a different way to their needs. So we work quite hard to keep frail elderly people out of our emergency department and out of our hospital. And you can see from that that we do significantly better than the rest of the country. Acute medical admissions, another key measure. So Canterbury's acute medical admission rate is 27% below the national average. If we were admitting at the same rate as nationally, we would have had 16,000 more people in our hospital last year. That's the scale of the difference, 16,000 more people. We would have needed at least 130 more beds than we actually have. We've maintained that gap now, as you can see, all the way back to 2006-07. People living in their own homes. One of the things that Canterbury, when we started this journey, was exceptional at was making sure that people got into aged residential care nice and early so they could stay a nice long time. So 50% of the people who ended up in long-term care for the elderly in 2006-07 would have still been there 6 years later. So what we set about changing that trajectory, and that was part of how we redesigned the health system. We're now sitting at somewhere between 18 and 20 months. So if you end up in long-term care in Canterbury, only 50% of you will still be there in 18 to 20 months. What that actually means is that people are spending longer living in their own homes, being supported by the system to stay well. It also means that rather than needing another 2,000 aged residential care beds for Canterbury, we currently have 700 empty ones. I'm not particularly popular with the people who own aged residential care, given that's largely a private business and they don't like having empty beds, but we're pretty pleased about the fact that we don't have those people in long-term care. Remember we needed 400 more beds by 2020? Well, if you look at this graph, what you'll see is apart from the peak in 2010-11, which is when we had New Zealand's largest ever natural disaster and broke a lot of the system with earthquakes, we have actually reduced the number of acute medical bed days in our hospital. Combination of keeping people well and healthy and out of our hospital and significantly reducing our length of stay. So our average length of stay for a general medicine admission in Canterbury is now 2.5 days. We're not quite sure that we can go much shorter than that because we'll be just about sort of discharging them before we admit them, but 2.5 days is pretty much our total, and that's counted from the moment they hit our emergency department. So what you can see here is the number of acute medical bed days in our hospital in this last financial year is only slightly higher than 2006-07. So no, we didn't need the extra 400 beds. In fact, the replacement hospital that we're getting sometime, you know what hospitals are like, it was due a couple of years ago and we might get it next year, we'll have 30 more beds. And that will be 2020. So instead of 400 beds, 30 beds. How do we do this? We have got a whole system working together. The way we work in Canterbury is we just get everybody in a room and we sort it out. And in this case, we decided that we needed to reduce the number of people in our hospital. We got everybody in a room. We had ambulance, we had primary care, we had the community-based services, we had the consumers, we had the hospital-based clinicians, and we said, there must be a better way of doing this. We could do things differently. So one of the things that you can see there is from the time we started this particular part of the journey, we have not increased the number of ambulances that are arriving at our emergency department. So 110,000 more people in the district and the same number of ambulance turn up each day for our emergency department. Why? Because we've given them the permission to do something different. So our ambulance officers, they have some clinical criteria and they know when they can leave somebody at home. They can take someone to a general practice. They can roll in an acute demand response, which is a complete wraparound service for people in their own homes. Or they can take the person to a 24-hour surgery, which is a general practice-led intermediate care facility that we also have. When we started this program for chronic obstructive airways disease back in 2012-13, we immediately reduced the number of people arriving at our hospital by 30%. The people who had rung the ambulance because they couldn't breathe. As part of that whole program, we also worked on reducing their length of stay, because what we discovered is that the only place that was using more bed days for chronic obstructive airways disease than New Zealand was Ireland. And our lead respiratory physician, who came from England, wasn't really impressed by that. So he decided that definitely we should be able to do better. So they set about changing what happened when people hit a hospital, as well as making sure people didn't get to a hospital unless they needed to be there. So we reduced the number of bed days for chronic obstructive airways disease from 8,900 at a peak down to 5,900 last year. Significant reduction. The year before, you might see, if you have a look at the blue lines, you see that in 17-18 it went up a bit. What happened, and this is one of the reasons that the Canterbury health system can do what it does, is that it has access to this data. Now you have the same system here in Ireland, your ambulance office system uses it. We use it for the whole health system. So it gives us good access to data, it also allows us to predict. In 17-18 we started to see a bit of a creep up. So our respiratory physician went round and met every ambulance officer in Canterbury personally and reminded them that they had permission to not transport people to the emergency department. And the next year we were back down again. Another program that we put in place, these are just examples of how the system solves their problems. Now, we haven't solved the problem of people falling and breaking their hips in hospitals. I think it's a worldwide problem and everyone tries to solve it, and we haven't solved it either. What we have done is solve the problem of people falling and breaking their hips in a community-based setting. So our clinicians said we need to stop these frail elderly people from falling and breaking their hip. It's a life-ending event, or it's an event that means they end up in long-term care. So we rolled out a community-based falls program, evidence-based, and we got the entire community to understand that if Agnes couldn't get out of a chair without using her arms to propel herself, she needed help. Really simple clinical criteria. Anyone can do it. In fact, we train the hairdressers because, of course, lots of elder ladies go to the hairdressers and then they can't get out of a chair. So the hairdressers then knew that they could refer for a response that taught Agnes strength and balance exercises, got her back on her feet, got her stronger again. The effect of that is nearly 1,000 less fractured hips than we would have expected. And that's not even taking into account the growth of our population. More importantly, our secondary care-based clinicians said the way we're looking after people when they hit our hospital with a fractured hip is wrong. It takes too long, they spend too long in a bed, we don't get them to surgery fast enough, we're going to fix that. And they did. And that's why we have saved 66,000 bed days over that 7-year time frame, because the amount of time that someone with a fractured hip spends in our hospital has now been reduced. And what that actually means is that if you do break your hip in Canterbury, you're significantly more likely to survive. One of the things that we measure from an equity perspective, if you look in the rest of the country, Māori have a earlier onset of morbidity, and they also have an earlier onset of mortality. So they die on average about 7 years earlier than non-Māori. In Canterbury, it is now 2 years. So we have managed to close that equity gap by the way we've designed services and engaged people in their process. At the rate at which we're closing that gap, in 15 years we will be at equity. And we will actually mean that the Māori population in Canterbury will live as long as the non-Māori population. Right now, the Māori population in Canterbury is significantly less likely to end up in a hospital. And in fact, the adult Maori population is less likely to end up in a hospital than the non-Maori population in the rest of the country. One of the things we have done as part of our development, and it wasn't until 2012, and this journey started in 2007, is created a shared health record. So we overcame all of those barriers to why you shouldn't share information. So we have a single shared health record. It's called Health One. It's available to everyone in the system. It seamlessly integrates behind the scenes with everybody's patient management system. It carries on it a series of plans. An advanced care plan, an acute care plan, and a personalised care plan. The real success story for us has been the advanced care plans. So this means that people's advanced care plans are sitting on an electronic health record that updates every 20 minutes. So because we know the oldest, the most out of date it can be is 20 minutes, everybody trusts it. So we have 98% compliance with people's end-of-life wishes as they are documented in their advanced care plan. That means that when we used to get 32% of the people over 75 who died in the year in 2011 would have died in the hospital, it's now 26%. And we think we can do better, because we just need to get more people to actually document their wishes in an advanced care plan. There's a whole lot of other measures of how the Canterbury system works. But the one I really want to point out to you is the one in the middle. Our faster cancer treatment. Remember when we started this journey, we were the worst in the country, and you were most likely to be delayed getting to your radiotherapy. One of the government's targets is faster cancer, and it's about getting to definitive treatment in a certain time frame. There's two measures, 31 days and 62 days. We exceed both. Compared to the rest of the country, we deliver 98% of our outcome within the 62 days. That is counted from the minute the GP makes the referral. So our general practices all have an electronic request management system that again integrates seamlessly into the background of their patient management system. All they have to do is put on that electronic request that this is a high suspicion of cancer, and the clock starts. So from the moment that a GP refers a patient that they think may have cancer, they're on the track, and we make sure that they get their definitive care as rapidly as possible. So that's a big switch for a system that was actually failing in the worst. Interestingly enough, and we're not sure why, so I can't answer the question, but we have 11.6% of New Zealand's population and 17% of New Zealand's cancer. So it's probably just as well that we're actually got very good at delivering it on time and quickly. I'm going to quickly run through how we do this. How do we create a system that not only integrates, and it's not perfect. I mean, there are all sorts of parts of our system that we all go, oh. But what we are able to do is solve the problems. So if something isn't working quite right, we can all get in a room and fix it. So we did this by building a platform of tools and services and infrastructure that enables the clinicians in our system to customise the response for the patient in front of them. We started off with a shared vision, a vision that was really simple to articulate, a connected system that's connected not just by IT, but also by relationships, by pathways, by people knowing how we do it around here, that is centred around people and aims not to waste their time. So the unifying metric in the Canterbury health system is the patient's time. And everyone in the health system has permission to make it better. So if they can see that there's some way that they can reduce the amount of time that patients waste waiting for the next step in their journey, they have permission to do it. We run the whole system off 3 strategic goals. Now, back in that time in 2007, we did that analysis because our board wanted to build a new hospital. Because doesn't everybody think the solution to the capacity issues in our health system is build more hospital beds? And so our board said we need a new hospital. So we did the analysis and said, yeah, if we keep on doing what we're doing, we're certainly going to need a new hospital. But we went to the board and we said, here's the health services plan you've asked us to write. Don't approve it. That was sort of relatively radical. We'd spent 18 months writing a plan, and we'd engaged 1,000 people, and we said, don't sign off on it. said, instead what we'd like you to do is sign off on these 3 strategic goals and allow us to reorganise the health system, to build services that support people to look after their own health, to develop primary and community services to support people in a community-based setting, with a single point of continuity, which for most people will be general practice, and to free up hospital-based clinician resources to stop them doing the stuff that they don't need to do, have them only do what only they can do, and have them support primary and community care to deliver what it needs to deliver. So a complete redesign of a health system, a refocusing on patients in their own homes and communities. To support that, we changed how we worked, because again we were that classic old-fashioned contracts, service specifications, financial incentives, how you're going to drive a system. We moved to a system based on trust, because actually trust is extremely efficient. It's a very efficient way of running a health system, and we based it on the opinion that everyone comes to work each day to do a good job, and if they're not, it's because we've got the system wrong. So we started to break down all those barriers and perverse incentives across the system. We changed our funding and allocation models. We changed our contracting frameworks, and we built a system based on trust that was about constant and continuous improvement. We used that measure of success as being the time that people waste waiting. The DHB's role stopped being telling everybody else how to do their job and started to being how can we help you do your job. And then we used information to drive service improvement and to plan and to manage our health system. We run it through a series of empowered networks, and I'll talk to you about those in a minute. I'll run you through the different networks that are actually how you can make a system work quickly and how you can make sure that you're getting good and distributed clinical leadership and consumer input in a health system. So essentially, the system is based on the clinicians are trusted, care pathways are redesigned, then we move the money and the resources to make it work. So we went from walking in the room and talking about the contracts and the funding to walking in the room and saying, how's this supposed to work for patients? You tell us how this needs to work and we'll figure out how to organise the system to support it. Consumers are part of the process, and we know that it responds really well to external shocks because someone has seen fit to test Canterbury quite a few times with external shocks. We are experts at mass casualty events, having gone through a number of large natural disasters and a terrorist attack. So this is actually adaptive leadership in action. This is about being able to adapt on the fly to deliver what we need to deliver. And in fact, our clinicians will now tell you we don't do crises. I will say never waste a crisis, it's always an opportunity. But they will say we don't do crises anymore. There isn't such a thing as a crisis. There's just another problem that we need to solve. So working differently, reorienting an entire system about supporting people to stay well in their own homes and communities, reducing acute demand, freeing up hospital-based capacity. Interestingly enough, we had a chief medical officer whose standard line was, there is no shortage of beds in a health system because there's always one in the patient's home. So, how did we organise that background infrastructure? We use alliancing. Now, we borrowed alliancing from the construction industry. We were looking for a model that was still contractual because we're bound by government rules of procurement and all of the other stuff that people have to work with when you're in the public health system. And we are managing $1.8 billion, so we have to do it right. But we needed a contract that reflected our way of working, based on trust, about relationships, a good faith contract. So we borrowed alliances. And we were very clear about who got to make what decisions. So the minister whose money it is in the first place, he gets to make a lot of decisions and decide what it is that the District Health Board needs to do. The District Health Board itself is accountable in statute, so they can't give up their decision-making power. But basically what we did is pushed as much of the decision-making as we could back to where the consumers and the clinicians meet. We empowered clinicians and consumers to make the right decisions for them. And in the middle, when we're trying to organise a system, we do that collectively as an alliance. So everybody in a room figuring out how best to make it work. So we run these kind of processes across our hospital. So our big acute tertiary, because we are the second biggest tertiary provider in New Zealand as well, tertiary hospital runs as an alliance, with the clinical leadership sitting around the table with some key executives like myself and the chief financial officer, deciding how many nurses, do we need another orthopaedic surgeon, what's the plan for the next 5 years, all doing that collectively so they actually learn to work more as a team. Across our district, we have the Canterbury Clinical Network, which runs a main alliance and then a series of service level alliances, which run our community services, run our laboratory services, our radiology services, all run in an alliance framework. So everyone who works in the Canterbury Health System belongs to the clinical network. Across our region, we have brought the 5 district health boards in the South Islands, it's about 1.1 million population, into an alliance. So we're collectively working together. We're using the same IT infrastructure, we're using the same pathways. Wherever possible, we deliver the services as close to where the patients are. So our paediatric surgeons work in all 5 hospitals. We don't bring the patients to us, we take the surgeons to the patients, because particularly with children. And then across our system. Now this is one of the things that made the Canterbury Health System work. People say, how did you drive this change? This is where we started, the Canterbury Initiative. It's a really simple model. It was 2 very senior GPs and an engineer to run the process. They were let loose in the system. They had no power, they weren't part of the system,